Welcome to the American Museum of Tort Law. We are presenting a three-part video series confronting the artificial stone silicosis epidemic, a unified approach to medical, litigation, and regulatory action. This growing public health crisis echoes past occupational tragedies, from black lung disease to the asbestos epidemic. In each case, it has been the civil justice system that has brought hidden dangers to light and driven accountability. Let's begin with part one.
Good morning, everyone. Welcome. My name is Melissa Bird. I'm the Executive Director at the American Museum of Tort Law. On behalf of the museum, I would like to welcome everyone here. We are having an important conversation today on the artificial stone silicosis epidemic. To our in-person guests, our distinguished speakers, our sponsors, and those joining us via webinar, thank you all for being part of this. People have traveled a long way to be here. Your presence reflects a shared commitment to understanding and confronting a serious and growing public health crisis. I want to take just one moment to thank my staff who has worked tirelessly to bring this event together. These programs do not happen by accident. They happen because of dedication and care and a belief in our mission. Thank you also to our local restaurants and our municipal government who is providing transportation later today, in providing delicious food, helping us to create a welcoming space for everyone here today. We were very much looking forward to speaking to Ralph Nader live today. He is the founder of this museum, but he was unexpectedly called away. He wanted to share a few words. He has given them to me, so I'm going to read them verbatim. Welcome to all at this East Coast Symposium on the spreading crisis of asbestos-like silicosis disease, linked to workplace exposure to crystalline silica artificial stone. This is also described as engineered stone or manufactured stone. Workers are dying or suffering serious respiratory ailments. Once again, as with the black lung disease from coal mine dust that has taken over 400,000 minor lives since 1890, to the asbestos epidemic of recent decades, it is the invocation of tort law by plaintiffs and their attorneys that break open the corporate secrecy to this preventable disease and moves the industry toward non-toxic slab materials by strong regulation. A considerable amount of cooperation led to the gathering of specialists at the American Museum of Tort Law today, whose mission is to provide public education about the law of torts, wrongful injury, and the civil justice system, including trials by jury. This initiative, led by attorneys Al Brayton and James Nevin and Melissa Bird, Executive Director of the Museum, reasserts the desired supremacy of the law over raw corporate power that affects defenseless workers. Consumers who like their smooth counters should be informed that the price workers pay and their families pay to make them is intolerable and must be replaced with available, safer manufacturing processes. May you have a productive day-long seminar and follow-up. Thank you again for being here. We're going to get started. But before I hand over the event to James Nevin of Brayton Purcell, partner, trial counsel, and national leader in the artificial stone silicosis litigation, he will be moderating the event today. I am going to welcome Al Brayton of Brayton Purcell, founding partner and national leader in products liability and toxic tort litigation. Thank you.
We're gathered in a place that is dedicated to a simple but powerful idea that when people are wrongfully injured, the civil justice system exists not as an abstraction, but as a means of accountability, truth-telling, and prevention. There could be no more fitting place for a venue for the conversations we're going to have today. Silicosis is one of the oldest diseases known to man. They found it in ancient miners. They found it in the lungs of people that worked on the pyramids. They had it in the Industrial Revolution in foundry workers and miners. And we thought that we were past that problem because through using engineering controls, more regulation, and working to control these types of exposures, silicosis was disappearing from the United States workplace. But yet today, we find ourselves in the middle of a new epidemic, one not inherited from the past, but one that was brought to us by our modern industrial economy. Over the past few years, a wave of young artificial stone countertop fabrication workers, many in their 20s, 30s, and 40s, have been diagnosed with a rapidly progressive, often fatal form of silicosis. And they are diagnosed after working with artificial stone countertops. Unlike the chronic silicosis of the past that was slowly progressive, this disease progresses at terrifying speed. And workers who one day are doing fine suddenly need to go on oxygen and or are facing the prospect of a lung transplant. The result of these exposures is a disease that is entirely preventable but incurable. We shouldn't have a problem like that. Today you will hear from leading physicians, scientists, industrial hygienists, and fabricators themselves who will walk us through the medical science of silicosis and how the exposure occurs, how the disease itself progresses, and why it looks so different and so much worse than what came before. Their work makes it clear that this is not a theoretical risk that we're facing, but a documented public health emergency. You will also hear from my partner, James Nevin, about the legal system's role when prevention fails. When juries are confronted with the evidence, they have understood the gravity of the situation. Verdicts are not anomalies. Verdicts are reflections of a community judgment that certain risks should not occur and should never have been imposed on workers that didn't know what they were facing. Tort law at its core exists to correct dangerous behavior and to force safer choices when voluntary ones have failed. You will hear the stories of the workers that have been working with these horrible products. And finally, we will discuss regulation. What has worked, what has not worked, and what must change. Around the world, jurisdictions are beginning to acknowledge what the science has long shown, that eliminating the hazard, not managing the hazard, is the solution to the problem. This is the top principle of occupational health, and it's a lesson that this epidemic continues to teach us, but at a horrible cost. Some products, no matter how beautiful or profitable, carry risks that cannot be engineered away. When we face that, the law and our collective conscience has to do something about it. And that's one of the reasons we're here today. The American Museum of Tort Law exists to remind us that accountability is not radical. It's foundational. It should be the basis of everything that we do. The right to trial by jury is one of the most effective public health programs we have ever had in this country. It forces truth into the open, forces accountability, and aligns economic consequences with the conduct. Thank you for dedicating your time to come here today to help us highlight the problems we're facing, for refusing to look away, and thank you for being part of a unified approach, regulatory, medical, and legal, to ending an epidemic that never should have happened. Thank you.
Before we get started, I want to thank our sponsors who are here today as well: Proceed, Passowix, File and Serve Express, and Veritex. And if you get a chance to talk to them and use their services, please do. So this morning, our first speaker, I'd like to welcome Dr. Robert Cohen from the University of Illinois, Chicago. He's an occupational medicine specialist.
Well, thanks everybody, and thanks so much for inviting me. I've been asked to speak a little bit about the global epidemiology, and then my colleagues, Dr. Gandhi and Dr. Fazio, are going to talk about some other aspects of this epidemic. How we learned about this new manifestation of the horrendous disease from silica exposure, and talk about it internationally. A little bit about the U.S., but Dr. Gandhi will talk about California and cover that more. And I think that I'll talk a little bit about Australia, but I know that Dr. Ryan Hoy's talk is going to talk more about the ban, but I'll cover a little bit about Australia, but try not to take away from his recorded talk that you're going to hear in a little bit. So this is from Sheiphali and Jane's work that they presented at UCSF a few weeks ago, just showing the most recent updated data on the numbers of cases of silicosis that have been reported by country and throughout the world. And so you can see that we're now probably close to 6,000 cases, but this is hugely underreported, given that almost all of these cases have been showing up at hospitals and clinics when they're very severely ill, and we still have woefully inadequate surveillance and screening to detect early disease. And I'm sure that it's really just the tip of the iceberg. So this is internationally, and you can see the numbers of countries that have been reporting cases. The largest numbers so far from Spain, which was the first country to report this disease, followed by Australia, and then Israel, China, and Israel and the U.S. But I think that these numbers, again, are huge underestimates. The U.S. data, California leads the way, not because it's a horrible state to work in, but because they have a really fine California Department of Public Health and have been doing great outreach and case finding. And I think that the other states, if we had that aggressive case finding and outreach, we probably have many more as well. So we'll talk about where this epidemic was first discovered, the home of Constantino, one of the main manufacturers. And it was in Asturias and in the Basque Country in northern Spain, and then Cadiz as well in southern Spain, where these cases were first reported. So in 2010, a clinic in Asturias reported 3 cases, and this is from Cristina Martinez, who's been very active internationally in helping us understand these epidemics and taking care of folks with silicosis. And they reported, young folks in their 30s with relatively short exposures with very severe disease. And that's going to be the theme of this disease, which I'm sure you're all aware of, is how short the exposures are in terms of tenure on the job, and how severe the disease is, and how young these folks are. And I think also a significant theme is that these are vulnerable populations. So a year later from Vizcaya, from the Basque Country in Spain in the north, they reported 6 additional cases, folks that were in their 40s with even shorter exposures, 13 years of exposure. And then in the south from Cadiz, the home of the Spanish Navy, they reported the largest number of cases to that date. That was in 2014. And they looked at the years 2009 to 2012 as part of an outbreak investigation, following up on 3 cases that were diagnosed at the hospital in Puerto Real in Cadiz. And then they found, using outreach and surveillance of peers of symptomatic workers, just kind of by word of mouth, finding out who worked with who, they found other cases. And then also 8 other cases also reported, self-reported, because they were learning about this, this new disease and this new epidemic. The age, again, in their 30s, and 26% had 30 years, so this is a bit more 30 years of age. The prevalence when they went back to some of these workshops was 20%. So 1 out of 5 workers with disease. And again, another part of the theme that we've seen in all these countries and most of these outbreaks is that they're mostly small family businesses and relatively short tenures of about 11 years. And when they actually started talking about some of the industrial hygiene components of these outbreaks, and they reported poor dust control, poor education regarding the hazards of respirable crystalline silica, and that there was poor use of personal protective equipment. The Israelis reported this artificial stone outbreak, and this was case reports that were first reported in 2012. And the sad thing about these cases is, again, we're seeing cases who are presenting not through surveillance, not through detection of early disease, but at a lung transplant center. So people that are already end-stage lung disease reporting to a transplant center. And Mordecai Kramer, who was the first author on this first report, and this was Caesar stone, although when they tried to report this in the literature, the journal Chest wouldn't allow them to use the term Caesar stone, but they just, they couldn't use the brand name. But anyway, they changed the name to artificial stone, and they reported that these cases of disease that were turning up at a transplant center, people that were exposed through dry cutting of these artificial stone countertops and bathroom fixtures, no dust suppression, no dust sampling, long working hours, and relatively modest exposures, a little bit longer, 17 to 22 years. And they found typical CT changes of silicosis and restrictive changes on lung function. 10 of these folks were transplanted, 2 had progressive massive fibrosis, none that they reported of the pathology had silica proteinosis, and 3 passed away. One of the other things that they noted in a subsequent article was the outbreak of autoimmune diseases, and I think Dr. Fazio is going to talk a little bit about some of the other manifestations of silica-associated diseases. The Italians reported cases from Siena, Italy, in the middle north part of the country, and they had 3 cases from their clinic in 2015. These folks were a bit older and a bit longer periods of exposure.
Okay,
and they were engaged in
thank you.
Installate.
I'm not going to turn my video on. No one needs to see me.
Mr. Lowry, I think we're hearing your microphone. There we go. Sorry about that.
I did say there'll be technical.
And they were also engaged, like we see in many folks, the fabrication. So not so much manufacturing, but we see so many people exposed who are taking these slabs, cutting them, polishing them, installing them. And they reported workplace exposures in Italy that were 20 times higher than the threshold limiting values for the American Council of Governmental and Industrial Hygiene. So huge exposures, and that's been common theme as well in these outbreak investigations. My colleague Ling Mao from Shanghai, China's Chest Hospital in 2019 reported cases, and this is a wonderful hospital in China, one of the leading premier chest hospitals, and she explained to me that these cases were referred from all over the country. They are sort of a central referral center, and they evaluated 98 cases from 2015 through December of 2018. These workers, like in so many countries, are migrants. They worked at unregistered workshops, so these are small operations, kind of the same mom and pop operations that we've seen here. And they worked, again, cutting, polishing, and grinding the material, working without appropriate PPE, and over half had chest X-ray and CT progression over 2 months to 2 years, even after their exposure ceased. And that's another common finding in this disease, is that these diseases, even when you remove workers from exposure, may progress absent further exposure, given the dust that is residing in the lungs. In the U.S., I'll just talk very briefly about this, and I will hear a lot more from Sheiphali about California. But these are the states that we've got reported cases from, and this is a little bit before the slide I showed you earlier about cases from the United States, so there's many more states that have reported. The first case was reported from Texas, a 37-year-old with only 10 years of exposure, and presented back in 2010 to his primary care provider, but had category C, the highest category of progressive massive fibrosis, with a 3/2, which is a very high profusion of small opacities and round opacities, very typical for silicosis, but horrendous disease. And Bob Harrison was involved in this report, and some folks from NIOSH as well. Then Cecile Rose and many folks that are here as well from many other states reported in the CDC's MMWR in 2019 cases from 18 other cases from 4 states, 2 deaths, and this is mostly cases identified through hospital discharge and the electronic health record data. So again, we're not finding cases through a wonderful surveillance program, finding early cases, but we're finding them after they've been hospitalized or are quite sick. They had rapidly progressive disease, they had features of autoimmune disease and atypical mycobacterial exposure. We'll hear more about that later. And again, this continuing theme of vulnerable, undocumented workers or workers out of status, folks that really feel very threatened if they would report to the healthcare system. In the California workplace had some exposure assessments showing 22 times the permissible exposure limit. And by the way, that permissible exposure limit of 0.1 is twice the current permissible OSHA permissible exposure limit. So these would have been 44 or 50 times the levels of exposures that we consider permissible now. And no systematic screening had been performed in these around these cases at that time in 2019. So I'm going to actually, I think, Sheiphali, I'm hoping that you're going to talk about all the California stuff, so I will just skip over these reports. Is that right, Sheiphali? You're going to talk about this? Yes, good, thumbs up. Okay, so skipping California, because we'll hear a lot more in detail from California, we'll go immediately to Belgium. And Ben Emery's group, Ben is a very active and wonderful occupational pulmonary doctor, and Steve Ronsman's. They reported in 2018, 2 cases of silicosis that were identified through chest imaging. An installer and a fabricator, again, not manufacturing. These folks weren't as sick, just mild PFT abnormalities and some impairment of their diffusion capacity, their ability to transfer gas from the lung into the bloodstream. And then they reported another 4 cases in 2020 with these skirting boards, which is kind of like at the bottom of flooring, they have these nice, beautiful artificial stone boards. And in these folks, they demonstrated accelerated lung function decline. And interestingly, and I think this is something that we should make sure that people think about, is that there are granulomatous changes seen in the pathology. And we've seen cases that have been erroneously diagnosed as sarcoidosis. When granulomas are found, people fail to consider silica as a cause of granulomatous lung disease. And I think that's really important that we think of silica sarcoidosis or granulomatous changes from silica and not dismiss the occupational history. The Aussies, I'm not sure how much Ryan is going to talk about this versus the process of banning the use of artificial stone in Australia. So I'll go briefly through this. I was working in Australia at the time with the reemergence of black lung, and we had instituted a new surveillance program for miners up in Queensland and in New South Wales, which was then really ported over immediately to this outbreak of artificial stone silicosis. Ryan and Deb Yates, colleagues from Victoria and from New South Wales, reported these cases from New South Wales. They were reported, again, to thoracic physicians, a little bit older folks, relatively small exposures, small businesses again. These were mostly Asian workers, vulnerable immigrant population in Australia. And like many places, they were doing dry cutting, no respiratory protection, no surveillance at that time, and they had 1 patient that was transplanted. My colleague, Katrina Newbigin from Queensland, looked at the Queensland surveillance data. This is a state-based screening program because there was a massive building boom in the Gold Coast just south of Brisbane. And they were putting up huge apartment buildings and throwing in lots of these artificial stone countertops. And there was a massive outbreak among stonemasons that were contractors working in those apartment buildings in that nice area of the Gold Coast of Queensland. And so WorkCover Queensland instituted a free state-based screening program. People could go and get a free CT scan, lung function testing. They did a fair amount of outreach. And in this first report that Katrina's group put together in 2019, they found 78 subjects, young folks again, 33 folks with a median of 12 years of tenure. 21% had PMF, progressive massive fibrosis, which is outrageously severe disease. 43% had a normal chest x-ray classified as by B readers, but they were all diagnosed by HRCT. So again, I think Sheiphali is going to show this as well. Chest x-ray screening may not be adequate to find early disease and only showing up a little bit later. We see significant changes on high-resolution CT scanning before we see it on chest X-ray. So in 2018, that's when Workplace Health and Safety Queensland began that screening. 2019, the Victorians took this to heart and began an important screening program. And they inspected all known premises that were fabricating engineered stones, and they required funded health screening. They didn't require screening, but they required that it be paid for. And they also banned dry cutting in Queensland and in New South Wales. In Australia, everything is state-based stuff, and so if it's good in one state, it's not necessarily a federal mandate. So each state has to provide its own regulations. And then some of the screening programs were reported by Ryan's group from Monash University. The state offered screening programs. They offered chest X-ray, spirometry, diffusion, and they did an HRCT as well. And they found out of 239 workers, 36% had silicosis, 65 had small opacity disease, and 21 had complicated or PMF. And they also found enlarged lymph nodes in people that had what we call lymph node silicosis, basically showing that the exposure's there and draining to the lymph nodes. And again, they found signs of collagen vascular disease, positive anti-nuclear antibody that we see in lupus and other collagen vascular disease, and 24% of those who were silica exposed, even though they didn't have silicosis, had positive ANAs, indicating a rather significant immune response to the exposure. And then following up on that same state-based screening program, they found more workers, more complicated disease, and they had, if they did have positive imaging findings, they had worse spirometry and worse gas exchange as would be expected. And the silicosis was associated with higher tenure, probably co-varying with older age and lower BMI. And they also reported dry processing as a common exposure variable. And then they did something which I think is also really helpful, to look at workers' comp claims. And they analyzed workers' comp claims in Australia for the decades, last decades, from the late 1990s through 2022, and found an increase, 27-fold increase in reported silicosis claims over the previous, compared to the previous 8-year period. So from 2015 to 2022 compared to the late 90s and early 2000s. And they also looked at the reports to the clinical registry, again, finding large numbers of cases. So 89% were found through WorkSafe Victoria screening. That's that state-based screening program. Again, not mandatory and not required, but just paid for by the state. And people were really encouraged through aggressive outreach to take part. Again, low tenures, 14 years of tenures, when we used to think of people getting these diseases after 20 to 40 years of exposure. And again, Asian immigrants, people that were vulnerable. And then the final report out of the Queensland government, the latest data I got was from last year, and they had 283 folks diagnosed with work-related lung disease. 38 of them had PMF, and the rest had small opacity disease. And others had non-silicosis respiratory disease, and that's just to remind everyone that these mineral dust exposures can cause COPD, they cause emphysema, and they cause changes that are not necessarily scarring lung diseases, but are important morbidities related to this exposure. Colleagues from National Jewish and our group at UIC reached out to as many countries as we could. This is back in 2022, and got data on 169 cases from as much detail as we could get from our colleagues in Israel, and that's supposed to be Spain, Australia, and the US. The age of the reported cases that we got in this study was in 51, with about 20 years of tenure. And how people found these cases was pretty much the best reports were from the state-sponsored voluntary surveillance, and many places it was just through hospital and clinic-based case reporting. 1/3 had progressive massive fibrosis, and 18% had less than 10 years of exposure, indicating rather intense exposures over short periods of time. Another finding, which I think Sheiphali will probably show us as well, is this ground glass opacity, these subtle small changes on CT scan that you wouldn't see on chest X-ray, and that we think also may be consistent with silica proteinosis, which we've seen in a more aggressive, when you get intense exposures, you get an outpouring of proteinaceous fluid into the alveoli. And our lung function showed expected findings of restrictive lung disease, low gas exchange on diffusion testing, low oxygens, and autoimmune changes as well. The UK was not to be left out, and Joanna Fury reported the first eight cases from the UK in 2024. Very similar stories that we're seeing here: young ages, low exposures, dry cutting, and then people coming in very, very late in their exposures requiring lung transplantation. So to conclude this part, no country really has instituted mandatory population-based screening, which is what we need. We must require that workers in this industry get screened so that we can get accurate estimates of the prevalence and incidence of the disease before they come in with advanced disease requiring lung transplant evaluation. Voluntary screening offered to all workers in the industry and paid for by the Australian state government is really the next best approach. I think that's been really helpful. We found lots of cases that way. And case series-based surveillance, which is being really well executed in the California Departments of Public Health, but I don't think has been really taken up by many other state-based departments of public health, can be supplemented. You do hospital and clinic-based surveillance and then outreach to those around those cases, I think is really important. Again, one of the common findings, workers are young, they're vulnerable, they have short tenures, and they come in with advanced disease, working in these small mom-and-pop operations. And we've actually seen the owners and the family members of these owners of these small shops with severe disease. This is a picture of this dust, and we have to, we're really at the very tail end of this one. We are diagnosing, treating, transplanting, and compensating people. We have to prevent these diseases, and that's primary prevention, controlling this dust exposure. And I'll stop here and see if I have time to present the Chicago cases, or I can hold off on presenting those.
We are ahead of schedule, so you definitely have time if you would like to present the Chicago cases.
Yeah, sure, I can do that, and I'm going to see if I can do that. Hang on one second. You can see these, hopefully. So these are cases, and Jane and Sheiphali have seen many times the numbers of these cases, but just to point out that that this is not just California, that it's in all these states, and we're really seeing these things just in many cases by chance. So my office here at Northwestern Medicine, where I have an occupational lung disease clinic, is right down the hall from our transplant program. And so we've been pushing very hard from the occupational lung disease clinics to have our transplant colleagues ask questions about what people do for a living, because that's something that still general pulmonary folks don't really do as great a job on, and often primary care as well. So that's one of the things we really have to push so hard in medicine, is to train people to ask people what they do and think about their workplace exposures as it relates to any possible disease. So our first case is the father, and he's actually came to us second, but he was interesting because he was referred to Northwestern Medicine because of the need for lung transplant. He came to the U.S. at age 27 from Caracuaro, Mexico, 30-pack-year smoker, and he worked at the shop that has been the focus of a major outbreak here in Chicago and a focus of OSHA investigations and OSHA penalties. So he had 24 years of work as a stonemason, mostly with artificial stone. And he worked from 2000 to 2024, fabricating these artificial stone slabs that are the big industrial slabs that they get in their shop and then they cut down to size. And he cut holes for sinks and plumbing and polished the edges. And he only used paper masks until 2021, and then water suppression, so basically dry cutting, water suppression was introduced in 2023. On chest imaging, he had silicosis with PMF, small opacities of the highest profusion of 3/3 according to the ILO classification system. His lung function showed severe restrictive defect and severe diffusion impairment, and he had really severe deterioration in his gas exchange. He was on home oxygen from 2023 and suffered repeated collapse of his lungs, pneumothoraces. And he received a bilateral lung transplant in February of last year, so he's about a year out now. This is just a picture of his, let's see if I can show this maybe. This is his lung function in June of 2024 prior to his lung transplant. So his vital capacity was 1.5 liters, only 41% of reference. You can see his tiny little lungs compared to what the normal shape of a flow volume loop should be. His FEV1, the most important measure of lung function, was only 41% as well. So a kind of a classic restrictive defect where everything is reduced universally about the same level. His lung capacity was only 40%. And horrendous gas exchange. His diffusion capacity was only 25% of reference. So you can imagine why he required lung transplantation. This is his CT scan. You can see he's got a whole blizzard of small opacities and then these conglomerate large opacities occupying the apices, the upper parts of his lungs. Then in the next, this is a few cuts further down, you can see that these large opacities have really almost entirely replaced any normal functioning lung tissue. So really just horrendous disease scarring that's occupied all of his lungs in the good old USA in Chicago. And these are the bases. You can actually see some emphysematous changes, but these large opacities and conglomerate opacities are really extending all the way down through the lungs, almost down to the level of the diaphragm. And then this was his silicosis. You can see those regular chest x-rays before his transplantation. Then after transplant, he got his new lungs. So he's exchanged one chronic disease for another chronic disease. We try to let our patients know that a lung transplant isn't like getting a new muffler on your car. You still have chronic rejection and many other medical issues associated with the lung transplant and chronic infections. And so certainly it's life-saving, but it is not the way we should be managing this disease outbreak. His son was interesting. He was 32 years old. He came to the U.S. at age 16, and his dad got him the job. He was working initially as a cook, and then his father said, I've got this great job in this fabrication shop. Come and work here. You can get good wages and get, have a decent life. And so he recruited his son to come work there. And his son, remember his dad started in 2000. His son came in 2012. Interestingly, for the first part of both of these folks' careers, they were working with natural stone. And then it really wasn't until 2016 when the shop really transferred over most of their production to artificial stone. I think that's why his father lasted so long with 24 years of exposure, but his son really only had maybe 7 years of exposure working and fabricating artificial stone in the same workshop as his father. He worked on those same slabs and did the same type of work, and again, the same environmental conditions and lack of personal protective equipment. His thoracic imaging also showed silicosis with progressive massive fibrosis, high profusion, small opacities, horrendous lung function, and gas exchange. And his disease was complicated by infection with fungi called aspergillus and repeated lung collapses. And you'll see from Jane and Sheiphali that these are common complications. And he had a bilateral lung transplant in April of 2024, so before his dad. And you can see he's got these cavitating masses in his lungs. You can see this is actually a partial lung collapse over here and a cavitation inside the large opacities. And again, this kid is 32 years old. He's got very young kids. And how his entire lung was occupied by this scarring disease. Almost again, all the way down to the diaphragm. Here's his chest x-ray prior to lung transplant. You can see the distortion. His trachea is all tortuous and pulled up because of the scarring and collapse of his lungs. And here he is post-transplant as well. So this is, again, just some of the common themes that we are seeing here. This new technology, new material. It's not rocket science to have understood that a material that's made of 99% quartz, when you fabricate it's going to cause silicosis, but somehow nobody really thought about that or took any steps. Vulnerable populations, small shops, poor engineering controls, inadequate protection. The treatments, we won't talk very much about it, but they're still really investigational and not very satisfactory. My colleagues in China are using this drug, tetrandrine, which we don't use. People have tried whole lung lavage in some of these really acute cases, but again, not very effective. And so that's the story from Chicago, and I think I will stop there.
Thanks, Dr. Cohen. That was excellent. Does anyone in the room have questions?
We have a question online asking, what should we ask of the Connecticut Department of Public Health?
In my mind, I think every department, State Department of Public Health, should require that these shops have mandatory surveillance. Now, these would be huge legislative changes, but I think that shops investigating, offering medical surveillance, which I really think should include full pulmonary function testing, spirometry, and diffusion testing, which can be done. This would be my dream of dreams. And then I think adding in high-resolution CT scanning, which is now low radiation dose and is lower cost, to survey these shops. That's what I think Connecticut should do. I think Illinois should do. And California is well on the way, certainly banning dry cutting and as well, I think would be very, very useful. That wouldn't be the Department of Public Health, that would be the state, OSHA as well.
Dr. Cohen, do you have any theories of why the state of Illinois or Chicago area, let's call it, is behind in terms of like a state like California in terms of the epidemic?
Well, I think Illinois should be much further ahead. We are a blue state, and we believe more in regulation as being a thing that's helpful. I don't know enough about the politics at IDPH and how much resistance that they're getting from industry, so I really can't answer that. Maybe Jane or Sheiphali have a better idea from what the different departments of public health are. But we are pushing with them. We are pushing them and trying. We've had them, advertise a little bit for us, and we've advertised. We do work with them in state workers' comp at UIC in the School of Public Health. We have a good relationship with them, so I'm a bit ashamed that we're not doing better here.
In terms of your patient count, besides surveillance, which you talked about, do you have any other theories as to why we don't see as many in Illinois yet as we do in, for example, California?
We're looking through workers' comp cases to get reporting. Again, occupation, industry, and these diagnoses are not part of our electronic health records. People aren't trained to ask these questions. Many of these cases I've had one case or a couple cases that were diagnosed as sarcoid, cases that were diagnosed just as TB. Because they're immigrant populations, people assume TB. I think that it's just, and we don't have, we actually, in Illinois, we're trying very hard in the recent year or two to go out to these shops and to approach people. We've had a problem with immigration ICE activity in Chicago that has scared people. We were really out there. We were getting some response. We were getting people to, and then ICE invaded Chicago, and people just went to the hill. So it's really a perfect storm of problems because most of these workers are Latino immigrants, or often may not be in status, and they're scared to death. My patients are afraid to come to clinic to leave the house, at least during the height of the ICE activity in Chicago.
I hope you don't mind. I have a comment on another reason we think we have so many cases identified in California. For a couple of years, which unfortunately this is now going away, undocumented residents of California were actually able to use Medicaid healthcare. And so many of the people who normally in most other states were not able to get healthcare were able to in California. Unfortunately, that is going away. It has gone away this year. But I think that's also why people, just when they access healthcare, they get diagnosed with things, just like anywhere. And so I think that's one reason why we have so many cases in California. It's just that people are actually able to access healthcare systems, and most states they are not.
Right, and here we actually got Northwestern and UIC to agree to provide free screening. And we went out with those leaflets, and we had our outreach. We have a Center for Healthy Work here at UIC, and our collaborators in different clinics were going out into the neighborhoods. But we got a very poor response because it did kind of coincide with, as I mentioned, this other activity.
Dr. Cohen, another question is, I've been unable to find any reference in the published literature in the 60s, 70s, 80s, 90s of countertop workers getting silicosis. And, you know, certainly there's plenty of other silicosis in plenty of other occupations published, but nothing specific to countertop workers. And I'm wondering if you've encountered that same finding, and if so, do you have any opinions as to why we didn't see silicosis in natural stone fabrication workers before the introduction of artificial stone?
Yeah, I'm sure my colleagues may have some thoughts about it as well. Certainly marble is 3% silica, so it's really quite low silica. Granite maybe up to 40%, I think, is the respirable crystalline silica content. So I'm guessing that perhaps they had a less severe, less intense exposure, and there was no surveillance. These are, again, small shops, so people might have had small opacity disease with some impairment. People would call it, TB, granulomas. I don't know why, but we certainly get construction workers and other workers, and they may have been just lumped in with that. But there's no union; they're not unionized workers. So there's, I think it was the intensity and severity of these diseases. These workers showed up for transplant that really rang the bell and got us all aware of it. But maybe Jane and Sheiphali have some thoughts as well.
I believe we have.
I think I agree with you. Yeah, I agree with you, Bob. I think the toxicity of the material is greater given the high silica content, and also I think it's like related to why are we seeing so much in California? I think both of you guys made excellent points about both case finding in California and just reiterating our access to medical care for folks without insurance is much better in California than it is in most states. So I'm just reiterating both of those points.
And let us know how you can keep ice away.
We don't either.
Yeah, let us know, please. We've had the same problem with our outreach efforts as well. We've had to pause a lot of the work that we were planning to do.
And since they've both started talking, I should probably introduce them to you all. We have Dr. Sheiphali Gandhi and Dr. Jane Fazio. Dr. Sheiphali Gandhi is an occupational medicine doctor at UCSF in California, and Dr. Fazio is an occupational medicine doctor at UCLA in California. And we do have some more online questions for Dr. Cohen.
Quite a few great online questions, but let's start with, what are labor unions representing workers in the stone industry doing to advocate for workers and mandatory screening?
I just want to say one thing. We're all lung doctors too. We love occupational medicine and but we are pulmonologists. We're very proud of our lung. That's our favorite organ, or at least mine anyway. But anyway, I think that the problem with these, they're not unionized. In any of these countries, these are non-union workers. They're small shops. And as I mentioned, even some of the owners of these shops have been getting disease. It was very interesting up in Queensland because we were working closely with the Mining and Energy Union, which is the coal miners union, and they were very, very active in helping the stonemasons do stuff. They organized workshops. They put a lot of pressure on the government to, because of the rediscovery or re-identification of black lung, they were very attuned to mineral dust lung disease stuff, so they were super helpful. And I think that in the States, we've been trying to get some of the bigger unions involved, the mine workers and the steel workers and others, but these are not their members and they are not organized. The construction workers unions, I think, that would be probably the biggest group that would be most helpful. And I think there's the Construction Workers Policy and Research Center, I think is interested in this, but it's a shame that when you're unorganized, you just don't have that power.
Thank you. Another question. Shouldn't we ban artificial stone?
I think that the answer would be yeah. I think that, it certainly is, it's a product that, I think as I said before, that we could have anticipated this outbreak, and we could have dealt with this much better. So I think banning these very high silica materials, I think makes sense. I think it's, they're all advertising their low silica products now, the Aussies, and I think you'll hear from Ryan about that whole process. So yes, and Jane and Sheiphali could talk about the efforts in California, which are way ahead of anywhere else in the States to ban, artificial stone. Hopefully if California does it, they'll just get rid of it for the whole country, because unless, if we can all follow California's lead. But I think that it's a product that really it's not necessary. There are substitutes, and one of the biggest tenets of occupational medicine is substitution of a dangerous product. If you have a material that you can safely substitute, then, so why use asbestos if you can use ceramics or fiberglass? Why use artificial stone of 99% silica when you can use, other materials? I see nods from my colleagues.
Great. Another question. Have you seen any incidences of silicosis in chip factories? So the manufacture of silicon chips.
I don't know of any. I don't know if Jane or Sheiphali had seen that, but I think that that type of silicon, it's silicon, not silica, perhaps. But I'm not. So I don't think that. And that what we need is what we don't need. But what is the implicated substance is respirable crystalline silica. So it's quartz silicon dioxide that's in crystalline form that fractures into these tiny, small, respirable crystalline particles that get inhaled deeply into the lungs. That's the dangerous stuff. Not silicon chip factories. I'll ask the Taiwanese because they make a lot of chips over there, but I haven't heard any reports.
I haven't either.
Same, and we have some chip factories in Northern California, and I haven't heard of any cases.
Okay, great, Dr. Cohen, thank you. And I believe next we are going to hear.
Okay.
You can stay though.
I'm just going to bug out. I have to go to clinic, but I want to thank you for inviting me, and I wish you a very successful end of your rest of your conference.
Thanks for coming, Doctor. We appreciate you taking the time. And I think next we're going to hear from Dr. Sheiphali Gandhi.
Hi, I'm Sheiphali Gandhi. So I am an assistant professor of medicine at UCSF, and as Dr. Cohen mentioned, I am both a pulmonologist and also an occupational medicine physician. I actually trained with Dr. Cohen at Northwestern for my pulmonary fellowship. So you can blame everything on him now that, if you don't agree with something, especially now that he's left. I don't have any financial disclosures or conflicts of interest with the presented materials in this presentation. So, as Dr. Cohen mentioned, I'm going to go back to California, give a bit of the story of what has happened here and what is happening here. But we want to kind of start, make sure that we know that the audience today is a mixed group of levels in terms of medical experience and understanding. So we'll go from understanding a bit about lung anatomy, what is silicosis and what are the forms of silicosis, and also some symptoms, and then finally I will talk about diagnostics, why CT scans are better than chest x-rays, and also what are the requirements of OSHA-based screening or like employer-based screening, and then also what is a pulmonary function test and what aspects of it are the most helpful. Okay. So first, just to tie back to Dr. Cohen's talk, I will talk a bit about California. So I moved here in 2019, and that is I was lucky enough to move here and come to start working with the California Department of Public Health around that time. My mentor, Dr. Harrison, who works at California Department of Public Health, had heard about cases that had been ongoing in other parts of the country, and much like many of the audience members know that product is also present in California, and we are very lucky to have an occupational health branch at our Department of Public Health that, rather than just 1 or 2 epidemiologists, has more than 50, and because of that, there's a respiratory group that works in the occupational health branch at CDPH. So essentially in 2019, they have a program where they're able to use hospital records and essentially looked for cases of people diagnosed with silicosis that were less than 60 years old, thinking that, essentially looking for cases of accelerated silicosis because, classical silicosis with lower exposures does not happen in younger people. And they found a case of a person in their, I think, late 30s, early 40s, who was diagnosed with silicosis. And they, through the case investigation, they were able to find this person's family member. The person had been admitted to the hospital in 2018. And one thing I will explain is that most of the cases that, and especially initially were found in California, were only found after someone had been admitted to the hospital, which usually is a sign of end-stage disease. And so in 2018, he was admitted to the hospital, and that is when he was picked up on administrative health records in the state of California that are reported to California Department of Health. But once they talked to his family, they found out that he was employed at a stone countertop shop from 2004 to 2013. And in 2013, he was diagnosed with silicosis once he began developing some symptoms of cough and shortness of breath. And over the next 3 years, he had worsening symptoms of lung function. And then in 2018, he was found to be ineligible for a lung transplant because he did not have good social support. And unfortunately, he died in that same year quite rapidly of accelerated silicosis. That case instigated essentially a full investigation of the workshop where this person worked. But also at the same time, cases were being picked up in Colorado, Texas, and Washington. And so once CDPH reported this to the CDC, they were like, hey, there's cases other places. They put them together in this MMWR report that was published in 2019, describing, I believe, 18 or 19 cases throughout these 4 states. And in California, there were 6 cases included. Because of that employer-based screening, so essentially CDPH worked with OSHA to do investigation of that original workshop where they screened 43 employees. And again, this was not mandatory because we do not have mandatory screening in the United States, but voluntary screening of 43 employees. And they screened them with a chest x-ray and a pulmonary function test. And a chest x-ray, as I've mentioned, is less sensitive for picking up silicosis, and I'll show why. But you can see that about 12% of them were found to have silicosis in this one workshop. And this is the workshop where Dr. Cohen mentioned that the exposure limits were 22 times the permissible exposure limit at that time, which was 100. So now it would be 44 times the current permissible exposure limit. But, if you look at other places like Australia, where they've done huge screenings of workers in the industry using a CT scan, they have found that the prevalence of silicosis is 22%. So, really they've been able to pick up a lot more cases, and people were more willing to participate, it seems like, overall, because of just they just have more legal protections in Australia. So really, when we estimate cases, and this is a very, very conservative estimation, and it is very, very hard to count the number of people in the industry in the United States. And a lot of that has to do with the fact that much of the industry is cash-based and unofficial, and so not really recorded in normal like Medicaid, Social Security records, or Medicare and Social Security records. The other issue is that many of these workers work as independent contractors, and so they may just put that they're a construction worker or that they're self-employed, and so those cases are often not picked up. And then finally, many of the workers in this industry are undocumented, and so may not participate in governmental based like questionnaires, census documentation, and things. And so it's a very difficult to estimate industry. But and finally, stone fabrication is very difficult to distinguish based on the way the cases are written down in the Bureau of Labor Statistics. They don't identify artificial stone workers and differentiate them from other stone workers. And often there's a mix between like stone workers who work in outdoor stone versus indoor countertops, and it can be very, very messy data. And so, but if we were just to be the most conservative and say there's 10,000 establishments with about 10 workers apiece, so about 100,000 workers, with the most conservative estimates, we can say that there are at least 12,000 workers in the United States with silicosis. But the numbers are probably greater, and I think California will probably show that based on the rates that our cases are increasing. So after this initial case investigation, this is when Jane, Fazio, and I became involved while we were both actually in training and residency and fellowship. And we, through partnership with the California Department of Health, and also many cases that were found at Dr. Fazio's hospital in Los Angeles, there was essentially a statewide hospital-based effort of essentially looking at cases that have been diagnosed, whether through hospital discharge records, California Department of Health, a lot of people just reported cases to people who work there, and also OSHA investigated cases, and we interviewed all of the patients and or their next of kin and reviewed their medical records. And in this initial report, which was published in 2023, there were 52 cases that we essentially studied. And you can see that the number of cases was increasing rapidly as the study went, as time went on, with the first case being found in 2010, but more and more cases up until 2022. And I think one of the things that was very unique about the group of patients in California is that they differ from many other countries by the country of origin, and how at risk they are, not only from a social standpoint, but also like a legal standpoint, with 98% being born in either Central America or Mexico, and then many of them being uninsured or through Medi-Cal, which is Medicaid essentially. And restricted scope Medi-Cal is essentially a surrogate for undocumented status, and many of them coming for their first presentation or first report of symptoms to an emergency department rather than through like OSHA screening or their primary care doctor, which you would hope that's where they would start. But many of them, because they had poor healthcare access, that was the only thing they could use. And vast majority of them were found after they had symptoms. And the goal with occupational health surveillance is that you find people before they actually have disease or they have very early signs of disease, rather than waiting until they've already developed disease, because by then it's already too late. And you can see that 87% of them had some symptom, generally shortness of breath as the presenting symptom, which is always concerning. The other thing is that 38% of them were first found with advanced disease, or what we call complicated silicosis, which has a very poor prognosis overall. And at this time, 15% of the cases already had been fatal. But really, we should not be finding cases this late. We should be finding them even earlier than in the simple, at the very beginning of the simple phase. And I just wanted to point out again, so when cases were found through active surveillance, which was essentially the OSHA investigation, you can see that many of those cases were in the normal, mild, and moderate range. This is just a grouping of 19 cases that were the first identified in California. But when cases were found through passive surveillance, which meant only found by California Department of Health after they had been admitted to the hospital, or through, essentially told to the California Department of Health through anonymous reporting, you can see that those cases were much more severe. And so really, we want to be finding cases here so that the Department of Health can do something about them. So where are we now? So one of the things that has really helped with the efforts in California, not only has there been a lot of outreach efforts, especially in the area where Dr. Fazio's hospital is, where there is really the epicenter of a lot of the cases, there's just been a lot more outreach and education done by the California Department of Health. But another thing that has really helped is media and also the legal, our legal partners who've also identified many cases and referred them to physicians for care. But another thing that has really changed things is that this last year, California made silicosis a mandatory reportable disease. So what that means is, like, for example, tuberculosis, which is a type of infection that is very contagious, pretty much in all states in the United States, when a case is identified, it has to be reported to the Department of Public Health. This is one of the first occupational diseases that has fallen into this category, and it is very, very unique. Essentially, when somebody is diagnosed with silicosis anywhere in California, each hospital system is required to report it to the Department of Public Health. The other thing is, through a partnership with the Centers for Disease Control, California has implemented something called, I can't remember what it stands for, but it's RCKMS, which essentially trolls all electronic health records in the state and finds cases of silicosis through machine learning, like some aspect of artificial intelligence. So all electronic health records essentially in California right now are being actively surveilled weekly for cases of silicosis. And then the epidemiologists at the California Department of Health, who are amazing, review all of the medical records and find cases of artificial stone. We are not at the point where that is moving into outreach, designated outreach at particular shops or like OSHA reporting. But, this is kind of the beginning of just finding the cases. But again, these are cases that are found passively. They're not found actively through OSHA or through employer-based screening. And there has been very few, essentially a trickle of cases coming in through that mechanism. And most of them are either being found through outreach by non-healthcare systems, especially legal outreach, and then also through just people getting sick and being diagnosed by physicians. And you can see that the huge number of cases that has increased over time. When 2023, this is where they were identified by CDPH and not actually when they were diagnosed. You can see in 2023, that's where I kind of started our story. Those were the beginning cases, but the huge increase that we're seeing is just very worrisome. You can also see in California that 57 people have already had lung transplants. And I think one thing people may ask is, why is there so many lung transplants in California and not in other states? And the thing is that or in other parts of the world. I mean, I think in Israel, they've seen a large number of lung transplants, and same with Spain, but not at this level. And it's because in the United States, we just have more access to lung transplants, is the honest truth. Many countries do not have lung transplant programs to the same level that we do in the United States. So many, and I have colleagues in Australia, they don't have lung transplants, and these lung transplants are very complex. And so many of the workers have died, but also the other thing is that many of they're identifying cases earlier, and so they are not as sick. But just to see how California fits in, you're like, oh, okay, this is going to level off, right? From the same poster that Dr. Cohen mentioned that we presented at a recent conference, you can see where California fits into the worldwide trend. Spain is where the first cases were found, and they have a very robust surveillance program and outbreak investigation where they, through the workers' compensation system, they identify those cases first, and they have not shown any sign of leveling off here. And these are the cumulative number of cases, but even then, they're adding cases every year at essentially the same slope or the same number of cases per year. You can see similarly in China and Australia that they're still adding cases every year, and at the beginning of this, we're behind them, and so we can only expect that the number of cases will continue to increase. And I think the rest of the United States is alongside with us with this. So I think this is going to get worse before it gets better unless we do something about it. So that's the story of California. Moving on now, I'll just talk about what is silicosis, just to give some perspective. I'm going to do this to start at a very beginner level and kind of move in increasing amounts of complexity from there. So to do that, I'm going to talk about the lungs, our favorite organ, but essentially on the left you can see the airways of the lungs. And the way that I describe lungs to people is that you have a main trunk, which is the trachea, or windpipe is kind of the other word that people use, that travels essentially from your the back of your mouth and throat all the way down to the middle of your chest, which is called the carina. From there, your lung airways split off into two portions: the right side, which this is looking at a person, and the right side and the left side, and these branch off into smaller and smaller aspects of lungs, of airways, just like a tree with its branches. And when you get to the very aspect of the airways, you have alveoli, which are these little sacs of 1 to 2 cell thick membranes that essentially is where oxygen and carbon dioxide are able to diffuse across. And if you use the same analogy where photosynthesis happens, these are kind of like the little leaves in your lungs, and they're very fragile. Here you can see this is what an air sac looks like, and it has a very thin layer of tissue with these capillaries, or like blood vessels that only one red blood cell can fit through. So they're microscopic, enveloping every single one of these little air sacs. So you can see how delicate these air sacs are, and you have these kind of at the very ends of all the thin branches of your lungs. Can we have a moment? I want to share my screen a different way because I just realized the way I'm sharing the animations are not working. Sorry, one moment. Just bear with me. Okay, there we go. All right, so, and when we think about like dust particles, the size of the particle changes what part of the lungs it goes to. And so here you have a human hair, which is about 50 to 70 micrograms. And here's like a piece of sand. So you can see how small that is. We'll talk about, and you'll hear Dr. Hallroyd and other industrial hygienists discuss, sizes of particles. So, for example, an estimation is that PM10, which is like dust, pollen, and mold, is five of those fit into one human hair. And then within that, 4 little PM2.5 size particles fit within 1 PM10, right? So that makes sense, like math-wise. So, you can think about how small these silica particles are. When you have these small, so the bigger particles, when you breathe in dust or sand and you breathe it in, it gets stuck in the mucus in your nose, and then you sneeze it out or you cough it out. It doesn't go all the way to the bottom of the lungs. The very, very smallest particles, you usually breathe them out, or breathe them in and then breathe them out. They don't go into the lungs now. There's more evidence that they probably may, but they probably go into your bloodstream, so we didn't know they were there, which is very worrisome. And then finally, PM2.5 is like the perfect size, which is what most approximately the size of a lot of the respirable silica particles go to the deep air sacs of the lungs. And essentially that is where they can cause problems in the very delicate aspect of your lungs. And so, again, this is like kind of the respirable fraction, that's what we call it. And that's like the smaller particles, and that's what we're worried about here. And so kind of like a higher level is like after somebody inhales silica dust, it gets to the alveoli during cutting, grinding, or drilling silica-containing materials. And essentially some of these immune cells called macrophages try to eat the particles and kill them because they think they're like a bacteria or something. But they can't kill them, obviously, but they put all these toxic substances trying to kill them. Eventually, because they can't kill the bacteria, and they essentially kill themselves in the process of trying to kill the bacteria. And this causes this inflammation and scar tissue forms around that area where the silica dust is. And the issue is that the silica dust stays. So rather than it being gotten rid of by these cells dying, the silica dust just goes and causes problems with more and more cells. And so even after people stop working, the silica dust is still there, and that's why many of them continue to get worse even after they stop working. And so after this process has started, it's often too late, and that's what we're kind of seeing here. In the beginning, and the goal really is to find people when they're asymptomatic, which means they don't have symptoms yet. But after that, what we see is people will develop symptoms of dyspnea, which is shortness of breath, cough, can be dry in the beginning, but eventually they can start to cough up mucus or sputum, more and more fatigue, chest tightness, and then low oxygen levels as more and more of the lung tissue gets destroyed. So now, you've maybe heard of different forms of silicosis, and so now I'm going to go to the essentially that portion where I talk about forms of silicosis. Please let me know if I'm taking too much time, but I just wanted to make sure that I explain things at a level that everyone can understand. And so first we talk about simple silicosis, and Dr. Cohen hates that word, but that's like the word that's been used for decades. But really, simple silicosis, or also called small opacity silicosis, what that means is that the very beginning, these small areas of scar tissue start to form around where the silica has embedded in the lungs, and makes these small little nodules that measure less than a centimeter. So a centimeter, is like about ½ an inch. So these small little portions in the lungs, and you can see that, these scattered little dots everywhere. There's just more dots than should be there. Usually it's most prominent in the upper parts of the lungs, because the upper parts of the lungs, air goes up, is kind of the way they quickly teach students, but that's where, things you inhale, you usually see in the upper parts of the lungs. You can also see that the lymph nodes in your lungs, and you can see it looks very full in the center of the chest, can show calcium. We say calcified, but calcium is a marker of chronic inflammation. And usually your lymph nodes are trying to pull all the dust and everything out of the lungs, essentially. And so many times it's a first sign of when we start to see people are exposed to silica. The lymph nodes will start to become large and show signs of chronic inflammation or calcium. Next, so here's another case. I wanted to include a couple examples within my presentation, but just to give some more help people identify. You can start to see area. This is a 35-year-old with 16 years of experience working as a stone fabricator. He was found to have these abnormalities, and because he had an accident. He was in a car accident. So we just got a regular image as part of that, and unrelated to the accident, they happened to find changes that were consistent with simple silicosis. And you can see this word chronic. I'm going to explain what chronic, accelerated, and acute means in a moment, so just bear with me. But you can see that in the upper zones of the lungs, you see these small little nodules, and then here you can see in the center part of his lungs, these this fullness, and then areas of brightness, which is calcium. That's like the same bone, bright like bone, because our bones are made of calcium. Okay, so now progressive massive fibrosis is also called complicated silicosis. And what that essentially is, as these small little nodules, as more and more of them develop and they form more and more scar tissue, they'll start to coalesce into masses that measure more than a centimeter. Again, it's usually in the upper zones of the lungs, but you will also see small nodules in other parts of the lungs as well. And eventually these masses start to affect the lining of the lungs, also called the pleura, or can even destroy lung tissue, and that can cause something we call like emphysema, which we often see in things like COPD. And here you can see, like, originally, here's the example where you have these small little dots or nodules. Just so you know, just for people who are not looking at imaging all the time, these are the blood vessels. They're not actually masses there. But here you can see that in the outer areas of this lung is mass, and that is actually just scar tissue from silica and not a cancer or something else. But Dr. Fazio will talk about that. Silica is a known carcinogen and causes cancer, so that's always something we need to keep an eye out for. But this is what we call complicated silicosis, or progressive massive fibrosis. And you can understand why. Look at how much the lungs are affected and why people are so sick after they develop this. And usually this is this level where somebody is starting to get towards a lung transplant. And so in this example, this is a 44-year-old. He had 12 years of experience as an installer. And he came to the hospital with symptoms. So he came to the hospital with symptoms of shortness of breath. All right. So now I'm going to talk about the third form of silicosis, which we also commonly call acute silicosis or silicoproteinosis. And I'll mention a bit why we call it silicoproteinosis. So this is a 43-year-old who was still working and had less than 10 years of exposure. Really had only been working with artificial stone for a few years. And he came in with 5 days of shortness of breath, cough, and chest pain. So, when we look at this imaging, you can see how it's different. You don't see those little dots or nodules. Instead, it looks almost blurred. And we call that ground glass opacities. And when they did a biopsy and they pulled some fluid from his lungs, it was white and cloudy, almost like milk. And then when they looked at it under a microscope, they saw that there were crystals in that fluid. And we call this acute silicosis. This can actually happen after even just weeks or days of exposure. But in these cases, we're often seeing them in less than 5 years of exposure with high levels of exposure. So this you don't see this when people have chronic low levels of exposure. It's after a huge amount of exposure, and many times these people progress. And when we say progress, it means get worse much faster. And so this is normal lung tissue. I think I mentioned how delicate and lacy our lung tissue is in this air sacs. You can see it's just like one cell across, and there's lots of air kind of filling, like with where you want it to be, essentially in the air sacs. Conversely, in this, and this is an example of a different patient, but you can see rather than those air sacs being filled with air, they're filled with this like fluid. And we call it a proteinaceous fluid or protein-rich fluid. And that's why it's called silicoproteinosis. And essentially what happens is the silica kills your immune cells that normally clear this fluid out of your lungs. Our cells are doing that every day for us. And your lungs fill with fluid, and people are almost like drowning in this fluid. When we pull the fluid out, normally the fluid we pull out should be clear or a little bit foamy. And you can see this is I generated this with AIs to protect people's privacy. But essentially you can see it's like a milky consistency. If we were to shine light on this, polarized light, which is like showing like I won't go into it, but we call it polarized light, you would see little crystals in this fluid. But the thing that you also see is you can start to see the beginnings of changes to the actual lining of the air sacs as well. And that's because in artificial stone, we're not only seeing acute silicosis, we're often seeing acute silicosis on top of the beginning of scarring. And this is what we're often seeing in accelerated silicosis. So this same patient, the one who had this blurry kind of appearance in the beginning imaging, what happened over a very short period of time. So the first image was in like early 2017. You can see this area of those, he started to form what like more like a simple silicosis pattern with those little nodules that I mentioned. And then you can see this area. I want you to keep a close eye on it and see how fast he got worse. So you can see in 2017, this is what it looked like. This is 2018, that those little nodules started to coalesce, that's what we call. And then already by late 2018, he got a lung transplant because he had gotten so much worse that fast. And so that's what they mean by this accelerated picture, that in situations of very high exposure, people will get worse much faster and also have these picture of acute silicosis, simple silicosis, and progressive massive fibrosis happening almost all at the same time. And that we often see, especially in artificial stone, we see that picture in accelerated silicosis. And that's why the nomenclature is so confusing and trips people up. And so just kind of to summarize, it's kind of like a nice slide if anyone wants to go back and review it. But you have acute silicosis happens in weeks to months usually, but we are seeing it kind of like happening between here. Acute and simple, usually the onset or like people get sick, have symptoms that happen really fast. They can have fever, weight loss, and very bad shortness of breath. And they come in with the appearance that I mentioned. Simple silicosis happens often after years, but it can also happen after decades. Often asymptomatic or, found when people don't have symptoms yet, or usually milder at this point. And then eventually, some of these can progress to progressive massive fibrosis even after the exposure ends. So here, progressive massive fibrosis is complication of simple silicosis with a high cumulative exposure. And they have progressive dyspnea, reduced exercise tolerance, and cor pulmonale, which means that it starts to affect their heart as well. Cor is kind of like I don't know if it's Greek or Latin word for the heart. And you see these huge opacities and masses. And then you may have heard, and just kind of going back to this slide, you may have heard, the word like acute versus accelerated versus chronic. And the way that I would think about it is that there's radiology findings that determine like silicoproteinosis, simple silicosis, and progressive massive fibrosis. But then there's this other word of like acute, accelerated, simple, or chronic, The acute, accelerated, chronic is only how long it takes for people to get sick and not how severe the disease is. So someone can develop disease very quickly, but it can be the complicated form of the silicosis, or people can develop silicosis very slowly, and it can be just the simple form of silicosis. And that probably is a combination of how much exposure they've had, and then also some genetic factors and other factors that we don't quite understand, because silicosis is a very neglected disease overall in terms of like medical investigation. Just kind of going back to some of the things that you'll hear later in the day, really the best thing is prevention. So people need to be surveilled and found early before they get to that accelerated pathway that we can't stop. Again, obviously eliminating the exposure or substituting with something that is less toxic. What engineering controls, we talk a lot about this. We can get into the weeds with it. But, we're very concerned that we're seeing cases in people who have used engineering controls. It is very difficult to do effectively. I will let other experts talk about this to you rather than me, but just wanted to, mention that. And also personal protective equipment, again, the last line of defense only. And really, at that point, you need a supplied air respirator. And P100 half-face respirators, really not that effective to be using 24/7 within these workshops, but it is being kind of used in other places in the world. But in California, we are now requiring supplied air respirators anytime somebody is fabricating stone. And then in terms of treatment, I'm not going to go into this too much, but there are some options. Again, getting people out of work. Some early treatment options of like antifibrotics, which slow the progress of fibrosis, but cannot reverse disease. And I want to be clear about that. It's not a cure. It only slows people from getting worse. And I do have to talk to many of my patients about that. Pulmonary rehab, keeping people, the rest of their body as healthy as possible, because they can really go down fast. treating any other health conditions they have, and then an end-stage disease, lung transplant, which is not available for many people who do not have insurance. We have been fortunate in California that so far many have been able to, but as I mentioned, those laws are changing with budget cuts and them cutting the ability for undocumented people in California to get health care. Finally, for diagnostic testing, I just wanted to talk a bit about discrepancies between recommended testing and regulatory requirements. And I think Dr. Cohen went into this, like CT scans versus chest x-rays, and I'm going to give you a pictorial example to really help you see why CT scans are so much better. So kind of going to the regulations, so this is the federal regulation, just to be clear. In California, we have an emergency standard, which is different, but since it's a national and East Coast-based conference, I'm not going to go into that too much. But in 2016, there was a law passed that required change the permissible exposure limit of silica to 50 micrograms per cubic meter. And I'm sure Dr. Halroyd will explain how little silica exposure that is. And as part of that, they required exposure monitoring, specified exposure controls, including respirators, and then medical surveillance. So medical surveillance not only has to happen at the 50 micrograms, but at the 25 micrograms, which is the action limit, or AL. And so really, we're seeing exposures much, much higher in this industry, but that is the regulation. So as part of medical surveillance, just to kind of mention, so, construction is one area where a lot of this has come from. If people are required to wear a respirator greater than 30 days per year, or in the industry and maritime, if they're exposed at or above the exposure limit. So these are kind of just like examples these are just like law-based examples, but it's kind of helpful for reference. But what does a medical surveillance exam require? So medical surveillance is supposed to be done at baseline, so before somebody starts working, and every 3 years. So as part of that, they're supposed to get medical and work history, which usually requires just seeing a medical provider, a physician, but can also be like a nurse practitioner or a physician assistant with some experience in occupational medicine. Physical exam, which examines the respiratory system, and then a chest radiograph, so just a one-view chest x-ray, but it has to be read by someone who is certified to read chest x-rays looking for pneumoconiosis. So silicosis is a type of pneumoconiosis. Pneumoconiosis is just a grouping of diseases that are caused by dust exposure. So it also includes black lung, asbestosis, and other things. Spirometry, which is a basic breathing test. It just looks at how much air people are able to move in one breath, one full big breath, and not only at like 8 to 10 seconds, but also 1 second. A TB test, and then it requires that if somebody has an abnormal x-ray or anything abnormal, that they need to be referred to a specialist. So this is what a basic normal chest x-ray looks like. And you can see that this is kind of like the lung, the way it looks, and how much overlap you have of all these different vessels and airways and lung tissue, but also that you have bone that's overlapped, right? You have your heart here, this is your heart, this thing in the middle. You have your spinal cord, you have all of your ribs, you have your clavicles. Here you can see the bones of the arms. You can also see that here's your stomach bubble underneath your diaphragm. And so some of your lung actually goes behind your stomach when you look at someone just in front of you. So you can see how difficult it could be to see things in the top of the lungs, especially with all these bones on top, or in the bases of the lungs with the diaphragm sitting in front or behind the heart. And so that is the issue with the chest x-ray. But in a chest x-ray for a B read, you really have someone who's like specialized to read these types of images. And I'm not going to go into like the weeds of everything, but essentially you get a perfusion score, which says how many opacities they see. the size of them, and they're rated based on P, Q, and R, which are letters, which is not very easy to remember. And then whether they're small and round or small and irregular. And then they also are given a rating of how many large opacities they see and how big they are. So you would see large opacities in progressive massive fibrosis and simple silicosis. You probably see small, round. Anytime, but remember this score, the perfusion score, which is the number, is the most important. So you are given two numbers, a one number, and then a slash, and then another number. What this means is the first number is what the reader thinks it is, and the second number is, oh, but they hedge their bets and say, but it could be this. So if it's 0/0 or 0/1, that's considered quote unquote normal, and that they don't need to be referred for any further testing. Anytime there's a 1, 2, or 3 in front, that means that it's abnormal and they need to get referred for testing in a CT scan, okay? And and then sometimes it'll then have the bit, like it'll be like a number, and then it'll say what like one of these letters, which says how many, like the size of these small round opacities, or irregular opacities, and then whether or not they have large opacities is a capital letter, so A, B, or C. And I love C because C is just larger than B, which, like, what does that even mean? I don't know. But, you know, the most important thing you just need to remember is if there's a number 1 in front, that means that they need to get a CT scan. This is what the form looks like. I just included this if anyone ever reviews medical records, that means that they have had a B-read. Okay, so look, this is a scan of here, let me go to this. So, here is an image of a person with silicosis, and you can see, like, at quick glance, it actually looks very normal. The airways or areas of the lung look nice and gray. But you can see there's mostly air there. This is your blood vessels. That's pretty normal to see. Same on this side. You don't see any big fullness in the center really, and so I wouldn't have a lot of concerns. A very good reader may see something up here, but it would require someone who's looking at these scans all the time, someone like Dr. Cohen, who looks at these all the time. But when you get a CT scan of this person, you can see there's some early changes right here. Do you see how it looks like there's like a little bit more dots there than there should be? And then you can also see, oh wait, there's a little calcium there. This looks a little fuller, which unless you're looking at these all the time, you're not going to know. This is a CT scan, and it cuts the lungs at layers, essentially like going front to back. And you can see why a CT scan just can pick up more, because you can see every single layer, and the stuff that was hiding behind the bone, all of a sudden, now you go back and you're like, oh wait, there are some little dots there. But I'm sure in the room where you are all sitting, it's very hard to see that. And here's another example. This is a chest x-ray, and it's not a very well taken one. It's because the person's in the hospital, so the quality is quite poor. Because they're laying in bed, they don't necessarily have their hands above their head. They're not taking as deep of a breath as we would like. You can just see it just looks a little bit wider than it should be. So I'm just going to show you an example of a CT scan. You can just see how much more information that we can see. So this is the same case I showed you earlier of the acute silicosis. And you can see how, probably if this person came to the hospital and they just said, I feel short of breath for a few days, the emergency doctor did not take an occupational history. They saw this, and the person says, I have a fever, I just have no appetite, I just don't feel well. And they're 30 years old, they're going to be like, oh, you have pneumonia. Here, I'll just give you some antibiotics. But when you look at this and you get a CT scan, you can see that there's just so much more going on in the lungs. I'm going to go back. I'm going to show you a picture of what a normal CT scan looks like. See if it works. See, this is what lungs should look like. Mostly black, because air is black on CT scans, with little dots in there. Those are your blood vessels and your airways, and that's normal to see. So you can see how abnormal this scan looks here. And so this is why a CT scan is just so much more powerful than a chest x-ray. We get so much more information. There is a way similar to the B-read where to rate CT scans is something called the I-Cord classification and looks at, I'm sorry, I don't know what happened with the formatting, but essentially it has 4-point categories. It also grades round and irregular opacities in the lungs, looks at emphysema and ground glass opacities, and grades that by lung zones. And it is, if you have trained radiologists who are used to doing this, it is as consistent between radiologists as the B-read. But there are very few physicians who are trained to do this in the United States, and so it is very hard to find the people who can do this. This has actually been studied, looking at CT scans versus chest x-rays. So for example, in Australia, there were 2 case series where they just looked at how many people had a normal chest x-ray but had abnormal scans. You see about a third or more than a third had a normal chest x-ray but an abnormal CT scan. It's a huge number of people that would be missed with just chest x-rays. This is also shown in Italy. Again, those with abnormal CT scans, only 42% of them had abnormal x-rays. And spirometry, which is the basic lung function test, only a third of them had abnormal spirometry. So CT scan just is so much more sensitive for picking that up. So on the same, I'm almost done, but talking about spirometry. So what is a spirometry? Essentially what you do is, this is a basic test that can be done in a clinic, it can be done in the back of a car, in a van, very transportable. And so that's why it's really been implemented. But the issue is that it only looks at mostly the large areas of the lungs, which are less impacted by silica. As I mentioned, silica gets into the deep portions of the lungs and really first affects how oxygen transports across. This does not look at that. This only looks at how much air somebody is able to breathe in and out and move in one big full breath. And really it's best used in things like asthma and COPD and less helpful in things like silicosis that affect the interstitial portions or like the outer portions or lining of the air sacs. And there is one test that is a little bit better. We call this a diffusion capacity. It used to be that the diffusion capacity was not very portable. You had to have somebody come to a pulmonary function lab, and it had very expensive equipment to do. But now there's some new machines that can do diffusion capacity portably that are now kind of we're looking at using in outreach efforts, but have not gotten to that point now yet. And this is not required to be used as part of medical surveillance, though I think we would advocate that it would be. It is a bit more sensitive, so in those who had abnormal CT scans, so we know they have silicosis, only 33% of them had abnormal spirometry, but 50% had abnormal diffusion capacity. In a similar lung disease or black lung, you can see that 9% of coal miners that had normal spirometry had an abnormal diffusion capacity. So you can say it picks up about 10 to 15% more people. And you also see that as the imaging gets worse, unsurprisingly, the diffusion or gas exchange gets worse as well. I don't think anyone would be surprised by that. So essentially, just to kind of summarize, CT scans and diffusion capacity, they are more sensitive than the federal requirements, and we do need an update. I wanted to mention, in California, as part of our emergency standard through California OSHA, we do require CT scans now. We do not require diffusion capacity because, again, CT scans are just more sensitive than the diffusion capacity, and we wanted we wanted the best test and trying to limit the amount of burden and limiting tests that would be less helpful. And so thank you. That's my presentation.
Dr. Gandhi, thank you so much. That was an excellent presentation. We have a few questions for you with just a few minutes for that. The first question is, you shared with us the different types of silicosis, for example, simple versus complicated or acute and accelerated and so forth. But for each of them, you simply use the word silicosis. Some authors have written that that's sort of a disservice to the public health aspect of this, because really it's artificial stone silicosis, and I'm wondering what your thoughts are on that.
Yeah, I think that's a good question. I think we're at the forefront of trying to understand the toxicological differences between artificial stone and pure silica exposure, and we do. And I didn't want to go too much into all the toxicology, because I know we have other experts that will be talking about that later today. So artificial stone does contain other things that are toxic, including plastic dust or microplastics. It can emit volatile organic compounds like styrenes, benzenes, acrylates, which we all know irritate the lungs, can cause asthma, can cause cancer, can cause so many other issues. There are also metal dusts, which on its own, that metal dust exposure does cause lung disease and scar tissue in the lungs. It can also cause sensitization, which is another word of meaning that it causes like an allergic response in the lungs. I think there's like nickels, for example, which are very classically known to do that. I believe can be cobalt and aluminums and other things that are also. And I think I did present more on silicosis. I think the reason is because clinically, other than the rapidity of presentation, we don't see differences in the way the silica presents in terms of symptoms or in terms of radiology. We have much more data on silicosis from all sources and not just artificial stone. As you know, it's a newer exposure. But these other compounds cause other lung issues. We don't know if these other compounds are adding to how fast people are getting this like pneumoconiosis, silicosis picture yet. But because we have seen in other outbreaks where people had huge amount of silica exposure, that people were getting accelerated disease as well. I think a good historical example is the Hawks Nest disaster, where they tunneled and blasted into bedrock stone that had high silica content in West Virginia. They saw many cases of accelerated and acute silicosis where hundreds of people died. Denim sandblasters in Turkey, I could keep going with examples. And they also saw acute and accelerated silicosis there. We don't know how these other compounds, we're very concerned about these other compounds, we don't know how they add to this silicosis picture. But what we are seeing is that these other compounds are causing other issues, especially asthma or airway disease, which Dr. Fazio will talk about more. And we're seeing higher rates of asthma than have been described before. I think we're at the very beginning of understanding that, but I have seen some very severe cases of asthma in people without silicosis as well. And so in Australia, they've described about 20 to 25% of people having asthma symptoms or clinical disease. And that's very concerning that there is a lot more going on than we understand right now.
I would like to add to that, and I'll talk a bit more about this, but I think the challenge with any occupational medicine or exposure in terms of understanding the outcomes of folks in terms of lung disease, it's very hard to, these people have mixed exposures, right? They aren't cutting the same slab over and over and over again for 10 years. And so it's hard to know how much is attributable to high concentrations of silica that are aerosolized versus high concentrations of aluminum that might be aerosolized versus any of the other compounds that Dr. Gandhi mentioned. And so I think it's very, very difficult to have, to say this is different because there are there are other different compounds. We think that might be the case, and they might have other issues that other folks didn't have, like asthma, chronic obstructive pulmonary disease, but we don't have the ability to really say that it's causing a different disease, because we don't have the ability to control the exposure and do a controlled trial where we expose people to only one type of thing and see if it's different, nor will we ever be able to do that, obviously, for ethical reasons. So,
yeah, I mean, only in Australia where they're doing like a real world study where they banned the high silica stone.
right, then we'll maybe know.
Yeah, and I think that will take decades to really know. Yeah, so I think we're at the beginning of that. Sorry, Jane. I didn't.
No, yeah, I agree.
Another question, Dr. Gandhi. As you know, the Cal OSHA Standards Board Chairman Aliotto recently adopted Cambior's proposal of sending out a letter to all the district attorneys in California, encouraging them to arrest and prosecute the fabrication shop owners. And I'm wondering if you have thoughts on if that would be an effective mechanism to reduce disease.
During that meeting, I did make a comment on that plan, so I'll say something similar to that. I am very concerned about that idea because, as we've mentioned, how at risk these groups are. When the ice raids were happening, as Dr. Cohen said, the patients headed for the hills. We stopped seeing them or have them participate in outreach efforts. We have patients who are very scared to come to hospitals. We have patients who have gotten transplants that are scared to come to their appointments when they're very, very medically necessary. And so as physicians, we are very concerned about anything that would prevent people from getting the care they need or getting to safe workspace. And so I just feel like, and the other thing is many of these workers, they don't have power or agency over the place that they work. Many of them have, when we've done studies, Dr. Fazio did an excellent qualitative study where they interviewed workers and just asked them about their experiences, and many of them expressed the difficulty that they have working in this unsafe place, but the push and pull of having to take care of their families and get food on the table. And on top of that, also now protect their families from any legal repercussions. So the more that we criminalize this, the less we're going to be able to help people. And I really feel like this will be counterintuitive, contradictory to our overall goal.
Thank you very much, Dr. Gandhi. Dr. Fazio, you ready to present?
Yes, I'm happy to be here presenting. I think Dr. Cohen and Dr. Gandhi have done an excellent job, and I pretty much agree with everything that they've discussed. I am tasked with talking about actually everything that is silica and silicosis adjacent. So probably because I see the large majority of silicosis patients out of anyone in a pulmonary clinic in this country. And so I have a lot of experience dealing with a lot of complications and concomitant conditions. And so I wanted to talk about those because I think there's a bit of less knowledge about that among this audience. So I'm hoping to kind of shed some light on the things that we're seeing in addition to silicosis. And I think Dr. Gandhi did a great primer on kind of what silicosis itself looks like in different stages. So my goals for the next 20 or so minutes are to describe, and apologies, I'm getting over a cold, but to describe non-silicosis lung diseases associated with silica exposure, so COPD, chronic obstructive pulmonary disease, asthma, and pneumothorax, and then to understand the non-lung comorbidities that are also related to silica exposure, so infections and autoimmune disease predominantly. So I just pulled this table from our initial kind of JAMA publication of 52 patients to give you a sense of how prevalent some of these comorbid conditions are. So of the 52 cases that we initially presented in this study, 12% had been diagnosed with an autoimmune disease at that time, predominantly rheumatoid arthritis, and systemic sclerosis or scleroderma, are and as well as myositis. And this is, I'm not going to get too much into the reason behind this, but as Dr. Gandhi had mentioned, essentially what happens is when someone inhales silica, the body identifies it as a foreign entity, just like it would a bacteria or a virus, and the immune cells in the lung engulf the silica and realize that they cannot break it down and cannot destroy it, and then they start sending out signals to other immune cells for help, and that is kind of starts the cascade of inflammation that we see that is silicosis. In that process, we sort of see a full-on activation of the immune system, which then is really kind of the definition of rheumatoid diseases, where the body sort of starts identifying its own circulating, what we call antigens or exposures, things in the body, and kind of fights against itself. And so that's really that's kind of the theoretical, if you will, mechanism of why we see a lot of autoimmune disease. And I'll get into a couple of this specifics later on. We also see non-tuberculous mycobacterial infection, which I'll get into. We see some pulmonary tuberculosis, which has classically been associated with silica or silicosis, and then we see a COP and asthma. So I'm going to get into most of these in some level of depth. So silicotuberculosis, I think this deserves its own slide because it is often, traditionally, I should say, in other exposures, tuberculosis and silicosis have gone hand in hand. And a lot of this is on a cellular level, makes sense because, as I mentioned, the cell defenses are kind of, the immune cell defenses in the lungs are decreased, and that kind of allows these mycobacteria to set up shop and start to replicate. And mycobacteria, as opposed to like a regular bacterial pneumonia, mycobacterium are actually like very slow growing. They're kind of opportunistic a lot of the time. So for tuberculosis, anyone can sort of contract tuberculosis and become diseased. But it's much more likely that exposure to TB and then disease that occurs later on, it's much more likely that sort of progression to active disease occurs in someone whose lungs are damaged for other reasons. And in this case, obviously, the damage is from silica. I will also say that especially, I work in Los Angeles County in a county hospital system. As Dr. Cohen mentioned, a lot of patients that I have are immigrants that come from classically or areas of the world that are considered TB endemic, so where TB is much more prevalent. And so oftentimes in medicine, when we see a patient that fits that social history, we have to think, okay, this might be tuberculosis. We have a higher suspicion for tuberculosis. And oftentimes it's when you get when you screen for tuberculosis in someone, the first step is an x-ray in someone with a cough. And the x-rays for patients with tuberculosis actually can look quite similar to the earlier simple quote unquote phase of silicosis. So these small micronodules that Dr. Gandhi showed, you can see here, I don't know if you can see my arrow, but on the lung, there's little white dots, and those are sort of the little white dots that appear in tuberculosis as well as silicosis. And so we have identified a number of patients initially who had gone through sort of the TB screening mechanism in the county of Los Angeles, and then had actually been started on tuberculosis-related therapy, which is a pretty intense multi-drug regimen, and didn't improve, and it turns out they didn't actually have tuberculosis. They had silicosis, and no one had asked about their occupational history, or they actually may have both. And so this tuberculosis you really have to diagnose by getting cultures of the phlegm out of the lungs, either inducing it or going in with a bronchoscope and kind of doing a wash of the lungs and sending that to the lab. So I think it's important to talk about, it's important that we always screen for tuberculosis in this population as well, because they can be coexisting, and also treat, obviously, if we find tuberculosis, that we treat for it as well. This is a patient that I actually have with silicotuberculosis. So I put a normal, these are chest CTs, and I put a normal for reference. And then, as you can see, the initial CT here from this person that actually I think had untreated TB, and then developed this on the right side, what's sort of a cavitary lesion here on the very far right of your screen. You see sort of like a big area of white with a hole in the middle. Can you all see my pointer or no? Yes. I don't know if you can.
Yes, we can.
Oh, you can. Okay, great. Okay, so here. And a couple other things I'll point out as well. You see, this is I don't know if you can tell, but this is a very large lymph node. So this is the windpipe coming down, the left main stem bronchus, the right main stem bronchus, and a very large, what we call station 7 lymph node. And we can see that in silicosis, but we also see that in tuberculosis and other inflammatory infectious diseases in the lung. So I know a lot of patients also have something called non-tuberculous mycobacterium, and we have a number of patients with this that we're treating, so I wanted to discuss it kind of in depth. So mycobacteria is this kind of family of slow-growing bacteria. We have tuberculosis complex, which we sort of already talked about, that's over here. Actually, leprosy is also in this cascade, but we aren't really seeing that, unfortunately. And then there's this big bucket of non-tuberculous mycobacteria. So these are actually bacteria that kind of live all around us. They usually don't cause disease in most people. They're sort of in the soil, in the air, and for the most part don't cause disease in people with normal immune systems. Now, in patients with silicosis, we just talked about how their immune systems aren't exactly normal, right? The silica inhalation causes this kind of overdrive inflammation in the lungs, which makes it more difficult for the lung to respond to other infections and easier for those infections to set up shop in the lungs. So we have two categories: slow-growing mycobacteria and rapid-growing mycobacteria. The rapid growers are aggressive. They grow quickly, just like it says. M. abscessus, for instance, causes abscesses. It can be quite severe, hard to cure. The slow-growing here are still difficult to cure, but we do have better clearance. And so what does that mean, right? These bacteria are slow-growing. So when you give an antibiotic, it's not that you give five days of antibiotic like a pneumonia and the person's done and they can go off on their own. Both categories are relatively slow growing, which means that it actually requires a year and sometimes more of triple antibiotic therapy to actually eradicate these bacteria from the lungs. And these infections can be quite debilitating for patients, especially silicosis patients who may already be debilitated, because one, the infection drives a lot of their symptoms oftentimes. So a silicosis patient without an infection may have, a dry cough, shortness of breath, but as soon as they start having symptoms of phlegm, also a lot of sputum production or like phlegm from the lower airways, and weight loss, fevers, chills, that's when, we pull the trigger on testing people for mycobacterial infections, which again requires usually 3 different samples from the lungs to diagnose, or a bronchoscopy to diagnose it. If we find it and we confirm that we found one of these infections, we're kind of committing folks to a year plus of triple antibiotic therapy, which oftentimes has many side effects and people have trouble completing. So it's no light thing, this infection. And we do work really closely with our infectious disease doctors to treat this. So what does this look like? So, like I mentioned, NTM is kind of our catch-all term for the non-tuberculous mycobacterium, so all of those categories at the bottom on the prior screen. And they're related to TB, but slightly different. They're sort of opportunistic infections that come into the lungs. So on this scan, you see they often cause what we call cavitary lesions, so basically big cavities or holes in the lung. So this is a very clear example of someone who either has TB or mycobacterium, and in this case, I think they had Kansasii, which is a subgroup. And it's important to note that these non-tuberculous mycobacterium are not contagious. As I mentioned, they're found in the soil and they're opportunistic, and they get into people's lungs who already have disease. We see this also in patients with COPD as well, and other fibrosing interstitial lung diseases. They're dormant in the environment, and they cause more chronic and significant symptoms, like I mentioned. And again, I mentioned the antibiotics and the treatment is poorly tolerated. That being said, in a lot of our silicosis patients, we do treat the NTM for a year or more, and patients actually do start to feel better in a few months. And so it is something that I look for frequently, because if we do find it, we can sort of attribute some of the lung disease actually to the infection, and we can actually reverse some of it, although we can't reverse the silicosis. So in our population, these are kind of preliminary results that have not been published yet. So you get like first view of these, but in the 73 patients that we identified before 2020, by the end of 2024, we found that 17 of them, or 23%, had a mycobacteria identified in their sputum. As I mentioned, sometimes we identify this bacteria in the sputum, but we don't identify it as causing disease, right? It can be like if you just sampled yourself, or if I sampled myself, I might have NTM grow out of that bacteria, out of my respiratory culture. But if my imaging is normal, then I don't. If my imaging is normal or not consistent with what NTM looks like on CT, then I wouldn't be considered to have the disease. So we have to distinguish between who is colonized with NTM and who actually has confirmed NTM disease. So of the people that had of the silicosis patients that had NTM isolated from the respiratory sample, the true sort of NTM disease people, those were 14%, so 10 of the 73. So this is a pretty high rate of NTM infection. And I will say, I mean, this was end of 2024, and we've continued to diagnose more and more NTM as time has gone by. But you also see that 10% are considered colonizers, at least at the time that we did this study. It doesn't mean that in the future they may not develop disease from that. And then for comparison, we actually, in this cohort, only identified one patient with active TB. And so in our US-based population, where TB is not considered endemic, albeit many of these patients are immigrants from TB endemic countries, we still are not seeing high rates of TB. All right, switching gears. So we talked about NTM, but the other sort of potentially more deadly complication is what we call pneumothorax, or collapsed lung. So this is a chest X-ray of a patient with silicosis who has had their left lung collapse. And in radiology, medical speak, left means right and right means left. So over here on your right is the patient's left. And this is the lung kind of the border of the lung kind of flapping around. And everything that is in the circle of the arrow that I am making, all of that is air, and it shouldn't be there. It's very black. So this is, and then this is the kind of residual lung that has collapsed here. And this can be, we think this is because a high rate of pleural involvement. And what the pleura is the lining of the lung. And so silica particles cause inflammation both inside the little air sacs of the lung, but the particles also travel through the lymph system to the lining of the lung as well. And in disrupting the border between the lining of the lung and the chest wall, which normally is kind of like two wet pieces of saran wrap moving back and forth to allow the lungs to expand and to inflate and deflate with every respiration, what happens is when there's inflammation in that lining, spaces start to open up and the lung can collapse because there's no surface tension. So we've been seeing high rates of pneumothorax, which hasn't been really reported as much in other causes of silicosis. Whether or not that's just due to reporting or actual incidents, I'm not sure. But we are seeing this a decent amount. And the concern is this can be an emergency, obviously. And what happens is when there's extra air in the space that is around the lung, then the air cannot, the lung cannot inflate into that space when you take a deep breath. So people go into acute respiratory failure, can die from this condition. And so we always kind of warn or give guidance to our patients about any sudden shortness of breath, sudden chest pain, sudden dizziness. They need to go emergently to the emergency room for treatment. So in our sort of 73 patients that we have in our hospital, since the end of 2024, 9% of them had one of their lungs collapse at a time, and then 5% had both lungs have collapse simultaneously, which is obviously much more dangerous. So this is a pretty high rate of pneumothorax. Here's some more pictures. So this is another patient. This maybe even is a clearer picture that I'm drawing the line where the end of the lung is, and then circling the big area of air. And actually, oops, sorry, you can see that actually there's a tether here. So because silicosis inflames the lining of the lung, sometimes the lung can be tethered to the outside of the wall. And that's actually, although it looks not good, it's actually better than having that lung fully collapse, because then you don't have those big pressure changes and you may not have what's called tension pneumothorax, or something that's as emergent of a condition. This is also, so panel B is shows you the treatment of this patient. So if you can see here, this is actually a chest tube that we inserted. And so it might seem obvious, but basically the way to treat this is you put a tube in from the outside and suck out the air. So you put a tube in the chest and put it to suction and reinflate the lung, usually for a couple of days, and then the lung sort of reopposes and hopefully stays up, and you can remove the chest tube. You can't always remove the chest tube. Sometimes there have been patients that, even though we insert the chest tube, the lung is continuously leaking air through what's called a bronchopleural fistula, or a hole between the lung and the outside of the lung. And then in those cases, I've had folks that have just been in the hospital for months and months and really waiting for a transplant because they really can't go home with this chest tube in place, unfortunately, in most cases. So switching gears. So Dr. Gandhi had mentioned sort of other concomitant lung diseases that occur commonly in these patients, whether due to silica exposure itself or some of the other compounds that we are finding in engineered stone. But one of the main ones is obstructive lung disease. So this is an umbrella term for both asthma and COPD. So asthma is a reversible obstruction, which means it's not, it's a disease that you can reverse with medications or removing exposure in the short term. And chronic obstructive lung disease includes emphysema, or really breakdown of the small air sacs, and remodeling of the tubes, the bronchi that lead to the small air sacs. This is a PFT I think you've seen a couple times in these talks, but what we look for, this is when the patient expires and when they inspire. And obstructive lung disease is when you see this scooping out, just like here, it's kind of this concave scoop that sort of shows us that they're having trouble exhaling. And that's the hallmark of what we see on a pulmonary function test in obstructive lung disease. In something like asthma, we may not actually see this because they may not be exacerbating. And like we said, asthma is reversible. So we may actually see not this, but a normal nice curve, which I didn't put here, but it's kind of the opposite direction. So convex. So in different studies, including some of our own and Dr. Hoy's in Australia, about 16 to 33% of silicosis patients have obstructive or mixed patterns of spirometry. So they have probably a component of chronic bronchitis or COPD or asthma. And I think it's important because this can be the driving factor of people's symptomatology. So I have patients with very mild silicosis, very early silicosis, that complain constantly of debilitating shortness of breath, difficulty with exertion or exercise, and it's predominantly because of obstructive lung disease. So whether it's asthma or COPD, and we have many inhalers that we use to treat them for this with variable levels of success, and usually it requires a steroid inhaler, which is complicated also because inhaled steroids are also associated with NTM, or mycobacterial infection. So sometimes we have to make decisions that may ultimately have the patient sort of exposed or have higher risk of developing non-tuberculous mycobacterium. So just sort of something that should be on your radar. And then as Dr. Gandhi mentioned, there are volatile organic compounds in these materials, like styrene, methylcrylate, and anhydride, which are associated with asthma and chronic constrictive bronchiolitis. So asthma, this is sort of a schematic of asthma. As I mentioned, people with asthma usually actually have normal lung function tests because they're usually doing the test when they are not in an acute exacerbation and they have severe symptoms of cough, shortness of breath, out of proportion to their silicosis. And this is essentially, asthma is a constriction of the airway that does not allow folks to exhale. I touched on this, but different engineered or artificial stones have upwards of 87 to 99% silica. So, but what is the rest? And I think the rest is possibly contributing to some of these asthma and COPD types of symptoms. So the epoxy glues and resins can sensitize folks or sort of cause asthma. The most abundant metals in one of the studies that I found on engineered stone that are aerosolized are aluminum, sodium, iron, calcium, and titanium, which are actually all implicated in asthma development. Volatile organic compounds that I mentioned, and also polycyclic aromatic hydrocarbons, which are essentially the same thing as what is coming out of an exhaust pipe of a car. So those have all been associated with asthma and are all found in high levels in engineered stone cutting. To clarify further, chronic obstructive pulmonary disease is just like asthma. You can see this same schematic here, but it doesn't improve. So this airway never sort of relaxes again once you have, once it's sort of become thickened. And you also have your little air sacs called alveoli and emphysema, which is also a type of COPD. You have breakdown of those air sacs, and so you wind up actually with people just getting sort of these thin-walled holes in their lungs, which are called blebs. So we see both of these types of chronic obstructive pulmonary disease in silicosis as well, and these are irreversible changes. Other diagnoses I'll briefly touch on. So silica is classified as a group 1 carcinogen. We think there's a dose-dependent response. And the challenge here is, folks are always asking me, have you found any cases of lung cancer? And the challenge is that, as you've seen, the CT findings and the imaging is so distorted in advanced silicosis that we think, I look at the scan, and most of the time I think and we kind of agree that the findings that would kind of look like a mass or a tumor in anyone else are really just PMF. And so it's very challenging as a physician to figure out who do we biopsy for cancer. So look for cancer. Where do we biopsy? And people will have multiple areas of consolidation. And I think, the only cases that are really clear are someone with very early silicosis who then have sort of one singular area that looks like a mass. And so, or have a spiculated appearance, which is kind of like a starry appearance. But I've only found, I think, one case of lung cancer associated with silicosis thus far. And one of my kind of projects is to actually look through the explanted lungs from transplant and see if there are cases that we're missing of cancer. I haven't heard of any so far. There's also overlap with sarcoidosis, which is another kind of inflammatory lung disease that causes granulomas. I think Dr. Cohen mentioned this. Silica also affects organs outside the lungs. So classically, people discuss renal failure or kidney disease. I haven't personally seen a lot of this, but the mechanism is really that the silica gets inhaled and moves into, this is from a mouse study, so you can ignore the mouse, but happens in humans and mice, and deposits in different organs, so lymph nodes, spleen, skin, liver, kidney, and heart, and you can actually detect it in the urine. You can detect past exposures of silicosis in the urine as well. I think this is my last slide. And probably the biggest category, which I'm not spending probably the amount of time it needs on it, but autoimmune disease, coming back to this. So autoimmune diseases oftentimes can be a presenting symptom for people. When I screen folks for silicosis who maybe didn't know they had silicosis or don't even have silicosis, oftentimes they'll say, I was diagnosed with rheumatoid arthritis 3 years ago, but they don't even have silicosis. So they can have rheumatoid arthritis most commonly with or without a diagnosis of silicosis, even if they just have silica exposure. And these are diseases that we can test with blood tests most of the time, although the blood tests are not perfect. Every time I see a new patient, if they have any symptoms whatsoever of joint pain, rashes, trouble swallowing, vision change, anything that's not in the lungs, I will do like a full autoimmune panel workup and refer them to rheumatology. And oftentimes, about 20% of our workers have these conditions from silica exposure. And we also always look for these because we sort of hope that there's we have treatment options for them. So the treatment options for these are different types of immunosuppression. So in someone with silicosis, sometimes I don't know if the silicosis or if the imaging findings I'm seeing in the lungs are due to only silicosis or due to also some of these autoimmune diseases that then also cause, in someone without silica exposure, these diseases can also cause a scarring lung disease or fibrotic lung disease. So we actually kind of sometimes hope that we find these diseases because we can treat for them and have some resolution of lung findings and lung symptoms as well, and some reversibility. And then I think this was just the renal slide. So silica-exposed workers have an increased prevalence of kidney dysfunction. Previous studies have found kind of a twofold excess in end-stage renal disease, which you can see kind of here. Talked about that. So in conclusion, silicosis in engineered stoneworkers is associated with high rates of concomitant mycobacterial disease, obstructive lung diseases, and rheumatological diseases. I'm happy to take questions if there's any time left.
Dr. Fazio, thank you so much. What is the impact of these other diseases that you just discussed today on the ability of a worker with silicosis to qualify for or get a lung transplant?
That's a great question. Depends on the disease. So for the infectious stuff, most lung transplant centers will not transplant an actively infected person who has not been started on treatment. So most lung transplant centers want someone with Mycobacterium kansasii, for instance, to have been on 2 months of therapy before they transplant because they risk having some of that residual bacteria in the airway at the time of transplant, which then can affect the transplanted lungs, which are immunosuppressed. And then some of the cases in abscessus, I've actually had centers decline or deny patients because abscessus is a particularly bad mycobacterial disease, and so they won't transplant them ever. On the other hand, with some of the other conditions, so pneumothorax or collapsed lung, I mentioned, that sort of is an indication for transplant. If someone has a pneumothorax that's not resolving, they can't go anywhere without a new lung, and so they sort of expedite their transplant. In terms of the other conditions, so asthma is not a transplantable disease, right? It's a reversible airway disease. So again, I have sent some patients for transplant evaluation, but their symptoms are predominantly asthma related, even though they do have silicosis, and they sort of say, let's continue to wait and watch and see if their actual lung volumes decline or diffusion capacity declines enough for transplant. So that's kind of, and then the other question here, we talk about extra organ involvement. So if someone's in renal failure or someone has a severe autoimmune disease that has caused other organs to fail, usually transplant centers shy away from patients with more than one organ failure. So if the lungs are the only organ that's failing, they're a transplant candidate. But medically, if someone also has renal failure that's usually probably the biggest one, renal failure or hepatic failure, they are less likely to be transplanted because they have multi-organ failure. So I think it's a complicated question, a good question, but those are kind of the things that I've seen the most often.
Hey, Dr. Fazio, Dr. Gandhi, thank you so much for your time.